Thank you for the generous introduction. Thanks everyone for having me. It's a pleasure to talk today about optimizing frontline treatment of CLL. And I'm sure you all have, as you said, you see CLL on a regular basis. It's a quite common condition, but probably not the most commonly treated condition, as I will show later on. So in CLL, we've seen really over the past few years a lot of new randomized data come in, a lot of new randomized prospective studies being conducted and trying to shape our treatment landscape. And I think this really illustrates, on the one hand, how common the clinical challenge of CLL can be, and also how engaged the community is in really establishing new treatments for our patients. Probably the biggest group of patients with CLL is the group that has no symptoms. So patients that are absolutely asymptomatic, where the diagnosis of CLL was made by accident during an elective surgery, for instance, or in preparation for an elective surgery, and where an increased lymphocyte is noted, and then we as hematologists pick these patients up, and then we do the diagnostics, see in the immune flow cytometry that the patient does have CLL. And then the patient asks what to do. And here we have already the first randomized data from the 90s, where a study was for the first time conducted in CLL in a randomized way, where patients with asymptomatic CLL either received chlorambucil or received watch and wait. And both groups, as you can see in this paper, had the same overall survival. So they didn't really benefit from early treatment initiation. And in our group, then we, over a decade later, started a study, CLL7, which tried to address the same question, but use FCR in these patients. And the most important finding of that study was, as you can see on the right, that patients receiving FCR in the red curve did not live significantly longer than patients who were managed with watch and wait. So again, we see that watch and wait seems to be a fairly reasonable strategy for patients with asymptomatic CLL. And our last attempt was from CLL12. In this study, again, patients with asymptomatic early-stage CLL were enrolled, and they were randomized to either receive ibrutinib or to receive a placebo. And again, as shown in the summer congresses just a few months ago, you can see on the right that the patients, the red curves, those who received ibrutinib, did not live longer compared to patients who were managed with watch and wait. Meaning that, again, there doesn't seem to be any signal that patients do benefit from early treatment initiation, and that we really should and have to wait until the disease progresses and becomes symptomatic, because only then do the patients benefit in the long run. So therefore, the treatment paradigm of watch and wait is still valid, and probably will be still valid for the next 10 years or so, I would imagine. And so we recently updated our German Oncopedia guideline, which is the guideline that we mostly use in the German-speaking parts of Europe. And I think it does have some general considerations that probably also apply here to the Middle East. So you can see, as first of all, on the upper left, asymptomatic disease, watch and wait. And then, based on two key stratifying factors, the TP53 status and the IGHV status, we distinguish between different patient groups. In the past, our algorithm looked much more complicated, where we also included things like fitness as a stratifying factor, and also included chemomonotherapy as an option. So you'll notice that in this guideline, for the first time, we removed chemomonotherapy, and we also removed the distinction between fit and unfit patients. And so the only difference that we have now in terms of the treatment options available is whether the regimen is given as a fixed duration treatment or as a continuous treatment. And for the fixed duration treatments, of course, we have the chemomonotherapy in theory, because this has always been a fixed duration option. We have venetoclax-based fixed duration treatments with CD20 antibodies and BTK inhibitors. And we have continuous approaches with BTK inhibitors. And here we have 3 approved options. If you look back at the different pivotal clinical studies that were conducted in CLL in the frontline setting, you'll notice that you can distinguish between studies that focus on the younger and fitter patients on the left, and studies that focused on the elderly unfit patients. And the reason why this distinction was made and why this was relevant at that time is that the patients who were young and fit tend to, or are the only ones that are eligible to receive intensive chemomonotherapy with FCR, whereas the elderly unfit patients these are the ones that used to get chlorambucil-obinutuzumab, which is better tolerated but less effective than FCR. So the reason why we had this distinction between fit and unfit was particularly driven by the chemomonotherapy component and the fact that we knew that some chemos are more toxic than others. With targeted treatments, though, it's very different. You can see that the targeted agents are being used on the left as well as on the right, and therefore the distinction is not that relevant anymore. So if you look, for instance, at the latest studies that we have, like CLL17 or MAGIC and other studies, we don't have a chemo component there anymore in any of the arms, and therefore we also don't distinguish between fit and unfit anymore. So these are basically all-comer frontline studies. In terms of the BTK inhibition, the continuous BTK inhibition, we have really thousands of patients who have been put into prospective studies, and therefore this is just one example from the ECOG 1912 study of a study that tested continuous ibrutinib and randomized this against FCR in young and fit patients. The study did show that if you give continuous ibrutinib, you have better efficacy compared to patients receiving FCR. And the interesting aspect about the comparison between continuous BTK inhibition and FCR is that if you look at certain subgroups, particularly the patients with IGHV mutated CLL, you'll notice that they have a similar outcome. And this is very relevant because it means that a patient that has received 6 months of FCR in the blue curve on the right has the same outcome after 5 or 6 years as a patient who has been taking ibrutinib each day for 5 or 6 years and still has the same outcome, even though the FCR treated patient had a treatment-free remission for 5 years or more. And so this really highlights that if we have a sensible way to give a combination treatment for a limited number of treatment cycles, produce a deep remission, that we can then provide our patients with considerable treatment-free remissions. And this was very recently, just 2 or 3 weeks ago, again demonstrated in this long-term FCR 300 cohort from MD Anderson, where they have now a median observation time of 19 years. And you can still see that in the red curves on the right, the patients who have mutated IGHV status, most of them who remain in remission after 10 years do not develop any relapses anymore. So this really highlights, again, consider that these patients received just 6 months of treatment. They have been in a treatment-free remission for over a decade now. So this, I think, highlights the possibilities that we can get from an active fixed duration treatment. On the other hand, we do have also issues with chemomonotherapy. So we know that particularly after 5 to 6 years, the risk for developing secondary neoplasia is quite considerable. And for FCR-treated patients, which in most cases are young and fit patients, this is of course very relevant, because even if you have an active regimen, a patient who starts FCR at an age of 55 has statistically a very high risk of developing a secondary AML when they become 65 or 70 years. And this is of course much more threatening than a relapse of CLL. So the high efficacy of FCR, and particularly in the mutated IGHV setting, does come at a very high cost. We don't have the same issue with BTK inhibitors, but we have other issues with BTK inhibitors. So we know that they have a distinct toxicity profile. We know that, for instance, with ibrutinib, there's a considerable cardiovascular toxicity in terms of atrial fibrillation, ventricular arrhythmia. We know there are sudden cardiac deaths that have been reported in many studies. We have congestive heart failure, issues with bleeding disorders, issues with hypertension. So these are all toxicities that are quite particular and distinct with BTK inhibitors. So even though they are quite active, ultimately we know from observational studies that this ultimately leads to high discontinuation rates. And so one way to address this issue is to use next-generation BTK inhibitors. This was the primary rationale for the introduction of agents like acalabrutinib and zanubrutinib, that they have similar efficacy but a more favorable toxicity profile. So this is from the ELEVATE-RR study, a straightforward head-to-head randomization between acalabrutinib and ibrutinib in relapsed CLL. And they showed that they have exactly the same median PFS, as you can see, 38.4 months in both studies, so non-inferiority, but less toxicity with acalabrutinib. So you can see over the time, for instance, on the left with atrial fibrillation, hypertension, and below on bleeding events in the purple curves, they are significantly less common than with ibrutinib. So in that sense, an agent that is better than ibrutinib in that regard, even though we need to appreciate that over the time, as you notice in these reversed Kaplan-Meier plots, the risk does also increase with acalabrutinib. So up to 40% of patients, for instance, develop bleeding events with acalabrutinib, which is still more than you would expect with chemotherapy, for instance. So therefore, as clinicians, we need to be aware when we have patients that are at an increased risk of bleeding due to their comorbidities or due to their co-medication, that we need to be aware of this issue also with acalabrutinib, even though it is more favorable than with ibrutinib. With zanubrutinib, we have another covalent BTK inhibitor that is also supposed to have less off-target effects and therefore reduce the risk of these side effects. And this is from the Alpine study, which also had a randomization between zanubrutinib and ibrutinib in the relapsed setting, and where there were significantly fewer atrial fibrillation events than with ibrutinib. Other toxicities like bleeding events, for instance, or hypertension were equally common with between zanubrutinib and ibrutinib. So the only difference here is really the atrial fibrillation. So overall, again, it is more favorable than ibrutinib, but the advantages are a little bit more limited than with acalabrutinib. The difference, though, is that with zanubrutinib in the Alpine study, there was also they also detected an efficacy superiority in terms of the response rate as well as the progression-free survival. Now we need to be a little bit careful in my view, because there are some statistical caveats in the study design that in my view I'm not 100% convinced that this is really more effective than ibrutinib. I think there are too many statistical caveats in the data set. So my conclusion from the Alpine study is that zanubrutinib is at least as effective as ibrutinib, but certainly less toxic. So therefore, I think acalabrutinib and zanubrutinib are more or less, when it comes to clinical decision-making, equal agents. In terms of the combination treatments that we have, there the data are still more limited than what we have collected over the last decade in terms of continuous BTK inhibitors. So the key established combination regimens are venetoclax with obinutuzumab or with ibrutinib in the frontline setting. And you will notice that with all agents that are currently under development and in the pipelines of drug manufacturers, you'll notice that all, or virtually all, are being explored in one way or another as a fixed duration or limited duration regimen. And the reason for this is that the rationale is quite clear, and the advantages that fixed duration treatment has are quite evident. So you expect to have less toxicity because the patient has to stay on treatment for a shorter time. You have less drug exposure. You have less, a more limited health economic impact by having a limited drug intake. We have less resistance development, which potentially could allow us to retreat patients eventually at some point when they relapse. So a lot of advantages in that regard. So one study that looked at fixed duration targeted treatment in the frontline setting for the first time with fixed duration treatments was CLL14, focusing on elderly unfit patients and comparing this to chlorambucil obinutuzumab and demonstrating, as you can see on the right, a longer progression-free survival. This is from the very recent data cutoff that we made and showed in the summer congresses, where we see that at 6 years, still over 50% of the patients are still alive and in remission, even though they have been without any treatment for more than 5 years now. We do notice that there are some subgroups like the TP53 aberrated disease where the efficacy is still more limited. So TP53 is prognostic also when using venetoclax obinutuzumab, and it is also prognostic, of course, in chemoimmunotherapy. But still, if you look here in the median PFS and for the dashed line, the patients who have TP53 aberrations, you'll notice that the median PFS is 52 months. So still over 4 years of disease control in half of the patients. So I think, therefore, it's still an active regimen for this group of patients. With the unmutated IGHV status, there seems to be, again, a prognostic impact, even though the disease, again, is quite well controlled with venetoclax obinutuzumab. Median PFS here is 65 months. And what's also particularly valuable is the time to next treatment. So not just the time until a progress develops, which in most cases can be managed with watch and wait, but the time until the disease actually becomes symptomatic. And here you can see again on the right that at 6 years, over 60% of the patients are still alive and did not require a next line of treatment. And bear in mind that these patients in this study have a median age of 77 years now. So this means that most of the patients in the venetoclax arm in CLL14 will only require 1 year of treatment in their whole lifetime because they are already now at such an advanced age. And in terms of overall survival, even though the difference is not yet statistically significant, we do see that the curves do separate and that there seems to be an advantage, particularly when it comes to the actual CLL-related mortality when using BCL2 inhibitors in the frontline setting. In terms of MRD, this is still, I think, rather exploratory and something that's not necessarily widely used in clinic. The important aspect here being that we can discriminate by the MRD status at the end of treatment between early and late relapses. So in the red curve here you can see patients who remained MRD positive after venetoclax obinutuzumab, which was roughly 15% of the patients. So not a huge group, but still a relevant one, because these have a median relapse time after treatment of roughly 2 years. So these are the ones that will eventually also develop an early relapse, and this information can be useful for some patients in the clinical management. And in terms of toxicity, this is also one thing that, as I showed in the beginning, is one of the key rationales of having a fixed duration treatment, the fact that when you stop treatment, you virtually don't have any toxicity anymore. This is true on the right for chlorambucil, but also for venetoclax. As you can see, after treatment, we don't pick up basically any toxicity anymore. And so this is a clear advantage to the continuous strategies where over time, the cumulative incidence of certain toxicities does increase. And then we also ran CLL13, which is the counterpart of CLL14, because this study focused on the young and fit patients. So in this study, the comparator was FCR and BR, as you can see above, and there are a couple of combination partners with venetoclax, including rituximab, obinutuzumab, and also the triple regimen of obinutuzumab and ibrutinib. So a lot of different hypotheses that are addressed in this study. The main finding being, though, that venetoclax and obinutuzumab, with or without ibrutinib, in the right two columns, provides substantially deeper remissions. 87% of the patients became MRD negative compared to just 52% with FCR, so clearly deeper remissions, and this very clearly translates also into longer progression-free survival. So as you can see in the red and in the black curves above, those are the ones that received venetoclax obinutuzumab with or without ibrutinib, and these had the longest progression-free survival, even more so than chemoimmunotherapy, our most effective chemoimmunotherapy basically. In terms of toxicity, we picked up already one interesting signal, which is that even though the observation period is just 39 months or so, we already now have numerically more secondary malignancies in the chemo arm than with venetoclax obinutuzumab. So including 4 heme malignancies, including secondary AML that already occurred in the FCR arm, whereas we didn't see any of this with venetoclax obinutuzumab. So this again is a signal that the risk-benefit ratio of targeted treatments might be more favorable. And then very recently, we also have now the combination of venetoclax with BTK inhibitor, with ibrutinib. And this is, of course, the key difference here to venetoclax obinutuzumab being that this is an all-oral regimen without any infusions that is given over a fixed duration. And this is, in fact, the only way at the moment by which we can limit the exposure to ibrutinib, or any BTK inhibitor for that matter. All BTK inhibitors are given continuously until treatment progression, and by combining with venetoclax, we are able to stop the therapy. And you can see this first in the Captivate study, which is a phase 2 study, which showed very nicely that for patients who received venetoclax and ibrutinib and who became MRD negative, if you give them a placebo, their disease-free survival and progression-free survival is non-inferior to patients who continued on ibrutinib. So this is really a very clear prospective proof that a patient who achieves MRD negativity does not need continuous treatment because their outcome will be the same. And even when you look at MRD rates, for instance, as illustrated here, you can see over the different periods of time until 36 months after randomization, the MRD rates are similar between patients with placebo and with ibrutinib. So this means that continuing ibrutinib doesn't even deepen the remissions compared to just taking a placebo. So I think a very powerful illustration that MRD negativity really allows you to stop treatment in this particular context. And then we have the phase 3 GLOW study, which also used ibrutinib with venetoclax as a fixed duration for roughly a year and compared this to chlorambucil obinutuzumab. Again, in elderly unfit patients, and you again see a clear efficacy superiority, 75% of the patients being alive and in remission at month 42. So clearly better than chlorambucil obinutuzumab. We again see that the MRD status tends to discriminate between early and late relapses. We again see that things like unmutated IDHV tend to be prognostic in the context of fixed duration treatment. And also in another data set from the Captivate study, we see that things like TP53 are also associated with shorter progression-free survival. So it seems that these high-risk features in the context of fixed duration treatments tend to be more prognostic than they are with continuous treatments. In terms of toxicity, again, we do see in the GLOW study that after end of treatment, there is virtually no toxicity anymore. So again, the proof that if you have a fixed duration strategy, you have less toxicity or basically no toxicity once you stop treatment. The issue being, though, that with ibrutinib and venetoclax, there is still some of the ibrutinib-related toxicity observed, even though it is just given for roughly a year. So you can see that higher grade atrial fibrillation occurred in 6.6% of the patients, and I think 12% or so overall atrial fibrillation rates. Also things like diarrhea occurred in up to 60% of the patients. So the toxicity profile is still relevant, even though the administration is just given for roughly a year. It is still a regimen that is particularly in elderly unfit patients, can be a challenge. So in our treatment algorithm, we tend to, when we use it more in the younger and fit patients, even though the GLOW study is conducted in elderly unfit patients. And therefore, in our guideline, we basically distinguish more or less between the hierarchy of using more continuous treatments or more fixed duration treatments, depending on whether the disease is more low or high risk. But I think we might still have to revise this a little bit more, because we expect to show more data at ASH regarding the fixed duration treatments. But ultimately, I think this shows that most of the patients can be managed very well with these targeted therapies, but we still have a lot of different questions that we need to address. Things like the question of which group of patients really benefits more from fixed or continuous treatments, implementing MRD and these kind of parameters. So there are a lot of different clinical studies looking into these aspects. The MAGIC study, which is a global study run from the US, where they are comparing acalabrutinib plus venetoclax to venetoclax obinutuzumab, both arms in an MRD-guided way. So this is more exploratory, but still, I think, will be a valuable data set. We are currently setting up CLL18, which will start end of next year, so late 2024, where we randomize venetoclax obinutuzumab to pirtobrutinib venetoclax with and without MRD guidance. So this is again a little bit more exploratory. We have CLL17, which is already fully enrolled with over 900 patients, where patients either receive continuous treatments or fixed duration treatments. So this will ultimately be really the ultimate data set to answer questions related to fixed versus continuous treatments. And then I know that the ECOG and the Alliance cooperative groups are currently setting up also studies comparing MRD-guided strategies to fixed duration or continuous treatment. So we will see more activity in that area as well. So with that, let me just quickly conclude. Based on the data that I showed, I think we can see that targeted therapies have really, across all groups of patients with CLL, have shown superiority over chemomonotherapy. Most of the patients that you diagnose with CLL in 2023 here will have a good disease control, a long-term disease control with the agents that we have. But there are still relevant subgroups, like the ones that remain MRD positive, the ones that have very high risk features like TP53 aberration plus unmutated IGHV and so on. These are the ones that are probably more tricky to manage and to offer a long-term disease control. So I think this is the area where we are more and more focused now to improve the treatment outcomes. So with that, I would conclude. Thank you very much for listening, and I look forward to the panel discussion later on. Thank you.